This is the DocNation podcast. We are a movement founded by doctors, for doctors, dedicated to empowering medical professionals to reclaim control over healthcare decisions and advocating for their fair share of the industry's resources. Please note, the views expressed are those of DocNation and not necessarily those of our guests or referenced health centers.
All right. I always get nervous about these introductions here, but Dr. Brian Rich, thank you for your smiling face joining us here. I know you're a busy man, just always been a leader in interventional pain and spine space, and it's been great over the years, kind of learning just exactly how far that leadership of that space and of doctors in general is extending to. And the things that you're doing in your free time, right? Kind of fighting for physicians, and that's what we do here at DocNation, right? We are trying to learn as much as about what's going on and trying to help doctors get a voice. And you are a big voice. I think you were telling us that you were representing doctors on the Hill.
Mm-hmm.
Can we start this conversation by saying what is kind of the update on the Hill and what are you doing right now?
Yeah, where are we going? So, well, first of all, yeah, thanks for that. Before I get too far in that, I will tell you there's a lot of really good doctors out there working with this as well, and working on these efforts. I think large in part because they're more exposure, and I think the more physicians understand really kind of how government works and what's happening, it's created more exposure. And because of that, it's allowed more physicians to get involved and understand how to get involved. Societies as a whole are getting more involved. I think all of them, there for a long time, there's really just one main society that was doing it. Now it seems like all of them are getting involved. And that's really helpful. And I'll tell you why, because if you go to the Capitol and you're standing there and you and you pound your hand on the desk, so to speak, really, 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 really loud, and I'm being very rhetorically here, and you make your point, you walk out and that sort of thing, that does not carry near as much weight as if you're the constant drumbeat. I'm still here. I'm still here. I'm still here. I'm still here. So
it's not a one and done thing. It requires continuous effort.
Absolutely. Absolutely. And so you can, follow up is the word of the day. And so anything that you do, you have to follow back up and make sure, hey, I'm still here. Every member of Congress staff, they have staff that you can just kind of keep hammering on and working on. So the creativity of really creating change, especially in Congress, is to keep coming at them in multiple different ways. Now, to answer your question specifically, I was asked to be, I think we talked about this, I was asked to be part of a congresswoman's staff as far as to kind of help her on her medical advisory board and those types of things. And it just started off very innocently, somebody I've known for a long time. And sure, next thing you know, bam, she's on Ways and Means. She's on the House and Energy subcommittee on Ways and Means, which actually is the controlling oversight committee for HHS, and which ultimately is CMS. So every government agency in the country has some form of oversight somewhere. And for us, that is Ways and Means, Health and Energy that committee. It really started out, about 3 years ago, just very slowly from, what's going on in 2474, as far as the equalization of Medicare reimbursement for physicians compared to hospitals. As I expected, the bill got introduced in committee. And it just kind of stalled there. And anytime now we're in an election year, we're trying to fund the government. Those types of things are definitely going to go on the back burner. However, the good part and about this, which is in no short terms, is kind of like what you guys are doing at DocNation and what other societies are doing, it's that constant drumbeat is starting to happen. And so, so my suggestion would be keep banging, because the more they hear it, the more they know they've got to do something about it. And I can't stress this enough. This is bipartisan. So when you look at any bill or anything that's put out there, that's sent to committee, there's always co-sponsors on both sides of the aisle, which is good. So these are all wins. These are things that are wins. The issue we have, and this is the real issue, and this is what people are now finally starting to say: Medicare cuts or anything, any changes in Medicare or any changes in healthcare spending has to be deficit neutral. So if something gets added somewhere else, it's going to have to get cut somewhere else, right? And you can see these trends occurring from one administration to the next, because
Brian, sorry to interrupt you here, but how's that the case? Because it seems like there are increases being made and there aren't being equivalent cuts other places. So why is it that this area has to be treated that way?
Well, generally speaking, the largest, the most vulnerable group for CMS traditionally has been the physicians, because the lobby is just not that strong.
Okay.
I mean, plain and simple.
Can you go into what is the lobby for physicians right now? I mean, I don't even think physicians know if there is a lobby or what they can support.
Well, the lobby that's supposed to be for physicians is the AMA.
Yeah, and that to me, I don't want to make you say it, but that to me has failed us over the last 10, 15 years.
Oh no, I'll say it. It has.
Okay.
It has. And the problem is that the AMA comes into negotiations, and they've come into negotiations trying to be conciliatory. Let's work together, so to speak. And the problem is the AHA, the Hospital Association, and the insurance lobby, that's not how they're operating. The insurance lobby in general, they have a fiduciary responsibility to their board to make money for their board
And to their shareholders. I mean, they're a publicly traded company, right?
It's absolutely correct. So but Justin, generally, you're supposed to be deficit neutral.
Yeah, that makes sense.
And I mean, as far as getting into the weeds and looking exactly what was added and what was cut, that's just why it's happening.
Mm-hmm.
So I'll give you a really good example as it relates to our space. Peripheral nerve stimulation. We all know about peripheral nerve stimulation. Peripheral nerve stimulation, for however you're using the therapy, has great success in a lot of areas. I mean, we can all talk about it. Obviously, if it's used appropriately.
Mm-hmm.
One of the major insurance payers, Humana, has decided that they are going to follow the Noridian LCD out in California and apply that across the country to all MACs, which it's not an NCD, it's an LCD. And what they say in that situation is they say that, well, that's Medicare. Well, that's Medicare on the West Coast. Mm-hmm. And that's the way that's how that works. And so now what's happening is when a commercial payer does that, and a commercial payer follows that guideline, then CMS tries to jump on that. Then CMS tries to jump on, well, we're only going to approve these procedures for the same thing. And that's against the guidelines of CMS. So you have to have someone literally watching almost every single thing of what they're doing and creating a checks and balances. And that is what the AMA is supposed to be doing.
And who are these people making the decisions at CMS? Are they physicians?
It's wide variety, but usually.
Okay. So take that what you just shared, if you could, Brian, and translate that to the patient level. Why does the patient care about what you just said?
Because an indicated procedure that could benefit them is getting denied, plain and simple.
So what the doctor tells the patient that they should have is then being denied by somebody else who's not involved in the patient relationship.
I'll make it more plain than that.
Yeah.
I'm Dr. Giuffrida in my clinic in Florida. I'm sitting here and I'm talking to a patient. I've worked them up. I've done all these things. You know, I may even have like one of his fellows standing next to me or something like that.
Mm-hmm.
We're talking about what procedure we're going to do that's really going to benefit you. Let's talk about knee pain, right? So we tried everything. We tried all these options and these things. And now we're going to take you to our procedure room and we're going to do a knee peripheral nerve stimulator trial. I go into full broad explanation. I get a procedure clearance. I talk about pre-op discussion. I talk about informed consent, benefits, risk. I talk about all this stuff. The patient is reading a brochure and everything looks great. And then they go home, they get scheduled. Now we've got to call the patient and said, well, guess what? It's denied. When we didn't even know it should have been denied, and now it is denied. And now the patient's going, well, what the hell does this doctor know? Why is he talking to me about this procedure that was going to get denied? And of course, he's over there going, wait a minute. He goes, should be approved. And now we've got to go fight it for two reasons. Number one, because I want the patient to want it. And number two, I don't want the patient thinking I'm crazy, that I'm suggesting a procedure that was never going to get paid.
As if you should have known better, and
exactly.
apparently you didn't. So do you really even know what you're doing?
Right. That's real world experience right there.
And for all the viewers out there, Brian, what percentage of time, I have two questions. What percentage of time do you think you spend talking to the patient about that? Because I have to preface with the patients, hey, I think this is what you need, but we might not be able to get this approved. And that's a lengthy conversation. And then what percentage of time do you think you and your staff are spending actually trying to get these approved? I mean, because we're talking about wasted healthcare dollars a lot in DocNation. To me, this is a huge waste of just the time we have to spend.
So pre-op discussion, depending on how you're scheduling and stuff like that, typically, as an established visit, if you're scheduling your established visit 15, 20 minutes and you think this is going to be a straightforward pre-op discussion, you could be in there talking to the patient in between 30 to 45 minutes, explaining the procedure to them. First, you're trying to get them to understand it, why you want to do it, why you think it will help them. Then you get into the bad things, the cons of the procedure. Then you talk about the good things, and then you talk about all the things. That could be anywhere between a 30 to 45-minute procedure. Patient walks out, schedules the procedure, and then all of a sudden it's denied. It could be weeks of time. It could be weeks of time trying to get it. And that could literally, if you have one, let's say you're a smaller private practice, which that's really where all the attacks are coming, by the way. But let's say you're a smaller private practice and you have one person that does all your prior auths, or you have one person that does all your insurance verification, whatever. That one person could be buried trying to deal with that almost all day long one day, which basically means all the other ones that they should be doing for all your other patients are not getting done because they're sitting here dealing with something that should have already been approved.
Do you think
that just bottlenecks your office?
Yeah, in my mind, I think it's a tactic to deter patients and deter physicians for wanting to go down that road and maybe not offer it to the next patient. And that's what I've seen.
Well, you're absolutely correct, and I 100% agree. Basically, I'll talk about the next point, but the way generally insurance companies are operating is they're operating in the sense that what they're trying to do is they're trying to wait you out. They're trying to sweat you out.
Yeah.
And there's actually supposed to be the next, and I don't know yet, but we're waiting. There's a couple of whistleblowers that are coming to testify in front of Congress that are the prior authorization physicians. Two of them are from Florida that were in interventional pain practices that left their practice and decided to go work for, I don't know if both of them went to work for Humana, but I know one of them did go work for Humana and is a medical director, and all they do is review claims. And on one of them, I've actually talked to him, and he's straight up said, it's what he said. He said the goal is for them to really just sweat you out, is just keep saying no until you finally just give up or the patient gives up.
So they left their practice, they retired their practice or whatever, they transitioned over to go full time over there.
And that's a whole nother headache.
And
why they did
now they're an insider at the company and they're exposing the corruption that exists, that
That's correct.
Doctors can't treat their patients the way they need to be treated. That's insanity.
Excuse me, absolutely. And I think the biggest part of it is they're treating it as a game, and it really is a game in a lot of ways. And again, when you go back to the reality of that, they have a fiduciary responsibility to their, as Dr. Giuffrida said, their shareholders, their board.
Yeah.
They're doing what they think is right. The problem with that, Justin, is this: is now Medicare in a lot of ways is trying to follow some of these crazy guidelines to try to prevent that, which that's a big no-no. And so that's a problem. And so those are the types of things that are starting to now get exposed, not because one person showed up in Congress and banged their hand on the desk one time. It's been a repetitive thing. And that's why I keep mentioning that this is the way this works is it's not a one-time thing, for it. I mean, and like, for example, I mean, I was talking with somebody a couple of weeks ago, and they said, you testified in front of Congress, and I actually, 10 times over the past 5 years, and they just kind of looked at me, and I said, but that 10 times in testifying in front of Congress, that really kind of equates to really once, because that's how it works. You almost have to do it 20, 30, 40 times before it finally starts moving things, because it's a big behemoth of a process to try to start moving things.
I want to say this, Brian, because I think, Dr. Rich, this. I've represented new technology, new medicine, and maybe alternatively said that I represent large investments, private investments, and even professional investments in new technology.
Mm-hmm.
And when we overlay some of the issues of the insurance denials and these types of things, you kind of look at this window of people that are actually cash pay for their health care, and even sometimes just traditional Medicare, are receiving better care.
So the best way I can respond to that, unfortunately I can't use this, but it's the best saying you can ever say. And now, there's some of the members of Congress are starting to use this. I wish I would have come up with this. I would have trademarked it. But just because you have healthcare insurance doesn't mean you have healthcare.
I've been saying that. I've been saying that since Obamacare.
Yeah, and so
yeah.
That's one of the big issues with ACA is they brought all these people in, but when they brought all these people in, they brought them all in with all the Medicare contractors, with all of the oversight against physicians. They made it just impossible for physicians. They put all the burden on physicians, and quite frankly, if in a lot of today's world, if you're a pure cash pay business, a cash pay practice, you're delivering healthcare more than if you're an insurance practice.
More efficiently, for sure.
That's
so those procedures that are getting denied, they're getting denied because insurance is denying that they're not going to cover it, right? That's the bottom line. And if you're cash pay, then the doctor can provide the patient what the patient wants.
So you used to, back in the day when your procedure was denied, right? When you would send in a prior auth for your procedure, it was denied. Yeah. It was so obvious why it was denied. You didn't do a test. You didn't have a diagnosis code. You didn't work this up. You didn't have this. Procedures are getting denied in today's world with perfect notes.
I think that even goes to the peer-to-peer interaction these days. I mean, the peer-to-peer interaction used to be, oh, hey, you forgot to put, the MRI attached to this. Can we go over the MRI real quick? And if we think it's right, then it'll get approved. The peer-to-peer for me now, and I don't know if you've seen the same thing, is they will say, we just don't approve this no matter what.
That's correct.
And I'm saying, why are we doing a peer-to-peer? This peer-to-peer is supposed to be a discussion between two physicians about a patient to see if we can do this procedure. And the number of times I've heard the peer, we'll use peer in quotes, that works for the insurance company say, and they have said this to me directly, I agree with you, this patient needs this procedure, but we can't approve it.
That's right.
Because it's someone above them. And to me, that we've just destroyed the peer-to-peer system. And it's more of just like a front to appease, check the box. Oh, they did a peer-to-peer, it's still denied.
So you have to have a peer-to-peer. Companies, commercial payers have to have a peer-to-peer because it's in their compliance regulation. Okay. Now, to that point, that doesn't mean that the peer-to-peer has to be one that's not tainted, like you just described, which is true. I've actually done a peer-to-peer before on a patient where I knew it was probably going to get denied because I knew it had happened before. And I was on the phone. It was a orthopedic spine surgeon, and I pulled the patient on a conference call so he could listen to the peer-to-peer. And it was enlightening, you know. And then the peer was just, look, I understand. I agree with you. I don't want to tell this patient I don't agree with it. He needs the procedure. But according to their policy denies it. That's the biggest issue in a lot of the commercial payers is because there's the way a lot of the policies are written is, you know, they have certain guidelines which allows them to deny these things. And there's nothing you can do about that from a commercial standpoint. But if it's the first thing that's going to be reformed are the advantage plans. That's the top of the list. That's as soon as they can get out of their own way and start actually doing work, you know, which, you know, probably will not be until 25. The first thing that's going to be reformed is going to be the advantage plans, especially from a prior authorization standpoint, because that's the one that's gotten the biggest drumbeat.
Well, the advantage plans to me are just totally out of line. I mean, when they were developed, they had to follow Medicare guidelines.
Right.
And I know there was an audit done last year where 80% of claims were not following Medicare guidelines. And then nothing happened from that.
That's right. It just went stale.
Denied claims, 80% of denied claims were not following Medicare guidelines.
That's right. It just went stale.
Yeah.
And so that's the problem with a lot of the advantage plans is the patients do the advantage plans, and when they do the advantage plans, they do them because they don't want to pay the 20%, but what they don't realize is that they're not getting all the Medicare services that they should be getting. Now, there has been some success on pushback with some of that stuff, saying you have to approve this because this is, you know, you have to approve this from a Medicare standpoint. But that's going to be the biggest. That's probably going to be the biggest overhaul, which is probably going to cause a lot of the advantage plans to go away.
Is there a way that physicians can shed light, or I don't even know if you can even use social media, but can they put some of these egregious denials out there for the public to see?
So, you know, there's two things that I always, you know, like, you know, and, you know, I used to be a big, you know, cheerleader for certain therapies and certain companies. And I used to teach a lot of different certain companies and things like that. I still am. I still believe in those products. I still believe in everything that everybody does. But what I've learned is, I'm going to roundabout way answer your question. But what I've learned is that, you know, the biggest thing that I've learned is that don't get on social media and criticize any therapy, regardless of what it is, whether you disagree with it or not. Don't criticize a therapy that has some sense of benefit. In the SI joint fusion world, there's been these battles with SI joint fusions about certain different techniques and approaches and things like that. And then you had various companies saying, yeah, see, well, you shouldn't use that because they're kind of fighting for their therapy. What happens is the payers see that and they're like, see, look at all these experts, look at all these peers, look at all these experts saying that that's not an approved therapy and that's not a good therapy. And they used a lot of those comments that they said were, you know, unsolicited to show that you shouldn't be doing these types of therapies because people saw them on social media.
Justification. Yeah.
That's number one.
Yeah.
Number two, getting online and letting people know about how a peer-to-peer went or how something went or whatever and how it got denied, you would think would light the candle, right? It really doesn't, because of the fact that it doesn't translate down into the patient making a big deal about it to their payer. And until the insurance companies can start to get hurt financially, then they're not going to change. The only thing that they will change is if somebody goes online and if they show somebody saying that this therapy is not effective or that therapy is not accepted, because they'll use that against the physicians and ultimately use that against the patients. It's going to come down in the form of sanctions, and that's what's going to change it. And that's
so you're saying that if the patient goes and says, hey, I wanted to get some treatment and I couldn't, and this company blocked me and they're preventing me from getting better, maybe not even being that specific about the exact procedure, but it just puts egg on the face of the company. that they have a bad reputation, that they're not.
It's the only thing that moves the needle right now with insurance companies, because then that particular patient can then say, look, I'm going to switch. I'm not going to use this Advantage plan anymore. Or I'm going to switch away from you, or I'm going to move to something else. You're not helping me. Now, that's a small person in a small situation.
Sure.
It would require a significant amount of people to start doing that for it to really start moving. But awareness to patients, or patients becoming more and more and more aware of what is really going on in the insurance world, about what therapies they're really not getting, is really what's moving the needle right now. So the more as physicians, or more as what we can do as physicians, is instruct the patient, this is why you can't do this. It's not because I don't want to do it. It's because your insurance company won't allow it. And here's where the reason why I think this has been such a hard, heavy lift for a while is because I think most patients believe that if their insurance company says it's not medically necessary, then it's not medically necessary.
Right.
That's so not true.
I think that wheel's turning a little bit, though. I think, 3 or 4 years ago, when we first started DocNation, physicians were, and obviously we got a bad rap after the COVID. There's a lot of studies that show they don't trust physicians as much.
Right.
But it's starting to be where patients are realizing, hey, the insurance companies are the bad guys here.
That's right.
And the physicians are just trying to help, hopefully. And I think, to your point, the patient is the customer of the insurance company, not the physician. The patient can move the needle way more than a physician can.
That's right. That's right. And I mean, it's going to require more than one patient to move the needle, right? It's going to require tens of millions of patients to move the needle. But what can happen in that situation, or what happens in these situations, is that the more patients are informed, and the better that they're informed as to what's going on, then that's when it's going to start truly happening. And I think you're right. It's patients are really starting to understand, my insurance is not, they're against me. You can look at the guidelines for radio frequency ablation.
Yeah.
Just, we used to be able to do multiple levels, great therapy, that sort of thing. Now and I tell patients all the time, it's like, they're expecting me to be perfectly right and nailing the area. It's really challenging, and it's really difficult.
It doesn't make medical sense either.
No.
If I do L4-5 and L5-S1, I can't go back and do L2-3 for 6 months or a year, just because it's in the lumbar spine, even though it's a totally separate joint. It's like saying if I do a knee injection, I can't do a hip injection for 6 months. It makes no sense.
Well, the Humana guidelines for PNS, right? They believe you should only do PNS after somebody has a total. So, which is, it was, that neuralgia cannot occur on its own without post-total. And it just goes against it just does not make any sense whatsoever. The more this stuff gets exposed, and the more this gets brought to light, and the more this comes to the surface, which is what I try to do. And when I talk, of course, I try to take as many stories like this from other physicians and other things that, I have enough on my own, but at the same time, it's like the more stories I get from more people, is that I just reflect this when we're talking about it, which helps.
Well, Dr. Rich, you have so many more questions that we want to ask you, but we'll have to do a part 2, part 3, part 4.
I'd love to get a part 2 after you come back from testifying in Congress, for sure.
Yeah. I don't know when it's going to be. They've got to get past the government shutdown fiasco, but and then
the election, and then all that. Yeah. So
it'll be next year.
One takeaway I want to offer out there to those that are tuning in is, if you have a patient that's having this issue, have that patient contact us. Contact DocNation. We can help your patients communicate this issue to get your patient's voice heard, which is ultimately getting you, the physician, your voice heard as well. So please reach out to us. We'll help you communicate, get the word out, get this issue exposed in a way that's professional, that's respectful, but ultimately gets this issue out in the public, so that way more patients can be aware of this. And so thanks so much for your time, Dr. Rich.
All right, let's see. It's good seeing you guys. Thank you very much.
Thanks for fighting the good fight.
Okay. Bye. This has been the DocNation podcast. If you like what you heard, be sure to subscribe, rate, and leave us a review on Apple Podcasts, Spotify, or wherever you are listening to us. Your feedback really helps us reach more listeners like you. We'd also love to hear your thoughts and any topics you'd like us to cover in future episodes. Don't forget to follow us on Facebook, Instagram, and LinkedIn for updates, behind-the-scenes content, and to join the conversation. Thanks for listening.